Welcome back, everyone. I hope you had a good break. We are going to get back into our agenda and head into the next session. I'm going to invite our next speaker up to the podium, Aimee Martin from West Cancer Center. She's going to present on genetic testing.
Good evening. Thank you for having me today. I realized I'm a little too short for this podium. Okay. I'm going to talk a little bit about genetic testing, especially cancers in diverse populations. Just a little background first. Many of you may know already, but 5 to 10% of cancers are believed to be hereditary, and genetic testing is available for many common genes. And testing's been available for upwards of 20 or so years. We had testing for the BRCA1 and 2 genes, the most common genes involved in hereditary breast cancer. Those were discovered in 1996, and testing has been available since the early 2000s. And since then, multiple more genes have been discovered, and there's been a lot of advances to technology, so we've been able to test for a lot of things and people at the same time. There are many guidelines for genetic testing that are out there, and I've listed a whole bunch of professional medical societies that have guidelines for testing, and this is probably not an exhaustive list. But what we know is that referral to genetics is often underutilized in U.S. patients, particularly in underserved populations. Several groups have looked into barriers behind genetic testing, and the most common barriers that keep coming up, and we've talked a lot about this already in regards to, oncology care, is lack of awareness and education for patients, lack of awareness that genetic testing even exists, and awareness sometimes about their own family histories. In regards to providers, on the provider side, there can be a lot of concerns about cost to patients and uncertainty whether a referral is appropriate. Geography can play a role. Patients who may live in rural areas don't have access to genetic counselors, language barriers, and of course, as mentioned, financial concerns are always a big thing. And lastly, confidentiality and trust concerns regarding privacy and how this information is going to be used. So in regards to the provider education, I just wanted to talk a little bit about wanted to point out some of the red flags that you can look for in your patient population and when you might suspect a hereditary cancer syndrome. A lot of hereditary cancers are going to occur much younger than the sporadic counterparts. So typically breast cancers under the age of 50, colon cancers, and even kidney cancers. The presence of rare or uncommon tumors in a family can also prompt a genetics referral. And also multiple cancers in a person, in a family, or if we're talking multiple, that even involves colon polyps as well. So anyone who's had more than 10 precancerous colon polyps should be referred. And with family history, that's one of the most important things too. When we see 2 or more family members with the same or related types of cancers in a family, we should think about a referral for genetic evaluation. Ancestry can sometimes play a role as well. So we know that individuals of Ashkenazi Jewish ancestry, for example, have a higher rate of carrying mutations linked to hereditary breast and ovarian cancer. But as we're going to learn soon, these rates can be higher in other populations as well. And as mentioned before, pathology can play a role too in genetic risk as well. Triple-negative breast cancers, for example, tend to be more associated with specifically mutations in BRCA1, BRCA1 gene, as well as some other genes. So this table here just shows some of the main syndromes genetic counselors historically receive referrals for, and it kind of illustrates the knowledge of how family history of specific cancers is really important and can aid in our risk assessment. And it just shows you that there can be overlap of cancers in different hereditary syndromes. So as a genetics professional, I spend a lot of time talking about specific family members and their specific types of cancers when I meet with them. In regards to hereditary breast and ovarian cancer, many of you know about the BRCA1 and 2, BRCA1 and 2 genes. These are the most common genes associated with hereditary breast and ovarian cancer. They explain about 40 to 50% of all hereditary breast ovarian families. They're tumor suppressor genes, so they're there to protect that patient from developing cancer. But a mutation in one copy can lead to significantly elevated risks. Especially for breast cancer, there can be a 50 to 80% lifetime risk of breast cancer, as well as increased risks of ovarian, pancreatic cancer, and even prostate cancer in families. The carrier frequency is not as uncommon as one might think. It's about 1 in 400 in the general US population, and even more common in individuals of Jewish ancestry, as I mentioned. There are some other genes that are also associated with high risks of breast cancer, but they're much more rare. CDH1, PTEN, SDK1, 11, and TP53. They all have specific cancer risks associated with them, and that's something we will evaluate all patients for, but generally they're pretty rare mutations. I just wanted to call to attention to the genes on the lower half of the screen. ATM, CHEK2, and so on and so forth, those genes have all been linked to moderate risks of breast cancer, and the ones starred with the asterisk, have been linked to moderate risks of ovarian cancer. And since our technology's advanced and we've been able to test more and more genes and more people, we're starting to learn more about these genes. But they're definitely less common than mutations in BRCA1 and 2. And really briefly, I wanted to mention hereditary colon cancer. There are many genes involved in hereditary colon cancer, but Lynch syndrome is the most common syndrome, and it affects 1 in 300 to 500 individuals. It may be a little bit more common in Black individuals, so it is something important to note. It accounts for 2 to 3% of all colon and endometrial cancer diagnoses. And typically, these diagnoses are a little bit more earlier than what you would see in the general population. The table, I know it's a busy table, but it's just showing you the cancer risks that have been linked to the 4 different genes associated with Lynch syndrome. And some of these risks will vary by gene. But the main risks, the main things that you'll see in a family history are colon cancer, most of the time in multiple generations of the family, endometrial cancer, gastric cancer, sometimes colon and endometrial in the same individual. So it's important to recognize. I am not moving forward. There we go. So medical management can differ depending on the gene I've identified. However, in most cases, identification of a hereditary syndrome will allow for earlier and more frequent surveillance. In the case of the BRCA genes and other moderate risk breast cancer genes, we may start breast cancer screening at a much younger age and even include breast MRIs for women. The identification of a gene can also open up the door for risk reduction, either by surgery or by taking medication. And in the oncology setting, sometimes knowledge of a BRCA gene mutation or even knowledge of Lynch syndrome can aid in treatment plans as well. So when looking at genetic testing data over the last 20 or 30 years, most of our information about genetic variances come from the non-Hispanic white population and individuals of Ashkenazi Jewish ancestry. This table here is just illustrating that mutation rates appear to be similar across different races. So it highlights the importance of educating patients about genetic testing. And I can't really, I don't have a pointer, I don't think, but if you look at the column under BRCA1 and 2 mutation prevalence, you can see that mutation prevalence appears to be similar across all races, if not a little bit higher in individuals of African and Latin American Caribbean descent. And there are, if you look even further into the specific types of BRCA1 and 2 gene mutations, we're finding there's some recurrent or population founder mutations too. So it's interesting. And while the frequency of pathogenic variants in a gene is the same across all racial and ethnic groups, race and ethnicity may be a modifying factor for gene-specific risk. I'm not going to go into too much detail about this plot here, but bottom line is it's just showing, if you look, for example, at BRCA1 and BRCA2, there are higher odds ratios and higher risks of breast cancer for individuals of Black and Hispanic ancestry for BRCA1 and BRCA2 versus non-Hispanic whites and Asians. Whereas if you look at the BARD1 gene, you also see higher rates among other races versus white individuals. So it's important. I think this is interesting data. There's probably a lot more we still have to learn. And we've only been testing for some of these other genes that are on this list for maybe the last 5 or so years. In terms of African American women with breast cancer, we know, as Dr. Vidal has stated before, the breast cancers are more often triple negative, they more often occur younger, and both of those are characteristics of women who have inherited BRCA1 mutations as well as other genes that kind of function in the same pathway. Most studies have shown that the majority of hereditary mutations in Black women are in BRCA1 and 2, but this particular study that looked at about 289 women with invasive breast cancer showed that 24% of mutations were actually in other genes. And all these other genes have important functions in DNA repair and can have other risks associated with them too. Triple negative breast cancer also appears to be associated with mutations in that PALB2 gene, and PALB2 kind of borders on the moderate to high risk side of things in terms of risk. Just wanted to briefly mention some other non-breast cancers and in diverse populations. I mentioned before the prevalence of Lynch syndrome in African Americans appears to be a little bit higher than non-Hispanic whites and Hispanics. And as mentioned by one of the doctors who spoke up earlier, we see an earlier age of colon cancer. So this is kind of important to identify a family history in the primary care setting. Prostate cancer, also another common cancer in men, especially African American men, and the rates of mutations are a little bit lower than what we would see for non-Hispanic whites, but the types of mutations that we are finding are very important and can affect those men in terms of their treatment and affect their family members, especially their female family members. And I wanted to briefly point out the HOXB13 gene, because an article just came out about it recently, but HOXB13 is a gene that explains roughly 5% of hereditary prostate cancers. It's not associated with any other cancers. What we know a lot about it is from the Northern European Caucasian population, and the article just recently found a founder mutation in men of West African ancestry that confers about a 2.4-fold increased risk of prostate cancer. So it's just interesting that, again, the more genes that we're identifying and the more people we're testing, the more we're starting to learn about differences amongst us. And there are other rare genes and mutations that are found in other specific populations. I just listed one here for Li-Fraumeni syndrome, a very rare, pretty aggressive cancer syndrome. There's a specific founder mutation in the Brazilian population, which is important. So in review, we know that there are a lot of benefits to genetic testing for patients with cancer and those unaffected by cancer with family history, but many patients may be unaware of these benefits. Genetic testing can help give patients a better accurate picture of their cancer risk, maybe put it in a little better perspective. Also allows for personalized screening recommendations, whether we find a gene or we don't. And it helps with decision making in regards to surveillance, lifestyle, preventative surgery. Can also help with anxiety and stress, again, by putting things into perspective. Sometimes I'm able to really reassure patients with their genetic test results. And then most importantly, genetic testing can help identify at-risk relatives by doing cascade testing. So whenever we identify a mutation, most of the genes we find are inherited in a dominant way. So their children, their siblings, all have a 50% risk of inheriting the gene, and we can offer testing to those relatives, often at very low cost to no cost. So despite the wide availability and known benefits of genetic testing, disparities do exist, and multiple studies have looked into the disparities amongst populations. So we know that very few people with Lynch syndrome and people with BRCA1 and 2 mutations have been identified in the population. One study looking at women with breast cancer and ovarian cancer found that only 15% of females had undergone genetic testing. And another group looked at discussion of genetic testing amongst patients and their providers and found that this discussion was 16 times less likely among non-Hispanic Black women and 2 times less likely among Hispanic women versus non-Hispanic whites. So how do we address this disparity? I think asking the right questions, again, starting at those first visits with primary care, gynecology, asking questions about family history, going beyond the parents, grandparents' history, aunts, uncles, all of that is important. And also the patient themselves. You might be seeing an older patient who had cancer 20, 30 years ago, and maybe just, it's out of their mind and they don't mention it. But they may not have had access to genetic testing back then. So, of course, recognizing the red flags that I mentioned before is also important. And most importantly, I think encouraging discussion, open discussion with family. And that's probably the hardest part. And the thing that I hear from a lot of my patients all the time is, no one in my family will talk about this with me. They had cancer, but it's behind them, and they're not going to have genetic testing. And some people just don't even know half the side of their family history, so it can be really difficult. I think it's important to educate patients by letting them know that genetic testing or hereditary testing does not equal cancer. It's just more information that can allow that patient more control and help protect themselves. So I always tell patients, if you've got a big family gathering coming up, a reunion, or if it's Thanksgiving, I know it's not the greatest time to talk about cancer, but that is when most people are available. So, trying to find ways to open up discussion, I think, and normalize things is helpful. And then lastly, clarifying misconceptions about cost and insurance. Insurance companies have become a lot more open and lenient about genetic testing, and our guidelines have become more expansive. So it's very rare that I have individuals who have genetic testing denied these days. Most insurance companies cover it, or at least 90% of the cost. And if there is no insurance coverage or no insurance at all, most labs do offer pretty low-cost self-pay pricing. And there are some financial assistance options through various labs as well. And most genetic counselors are going to be aware of the main labs that offer these programs, so it is good to find one of us if you can. I know there's not many of us in Memphis, but and that leads me to my last point. There is improved access to genetics now with telehealth, and there are companies that are designed solely to provide genetic services to you. And that might be really important for people that are in rural areas or don't have great transportation or physical mobility limitations. And I listed a couple companies on the slide, but that's not an exhaustive list either. So in summary, pathogenic variants in cancer genes have been detected across all geographic regions. However, not all populations have had the option to be tested. So genetic risk assessment is integral in comprehensive care today of today's patient, and I think primary care physicians can play an important role in that identification process. And by encouraging patients in discussion in the clinic, encouraging discussion within their families, I think you can open the door for enhanced screening and cancer prevention and risk reduction, so improving disparities for sure. And that is it. If you need any more information from me, I'm happy to give it to you. You can always email or give me a call. Oh, I already have a question.
I have a question. Aimee, I've got a question for you.
Yes.
So thanks for bringing up that point about family history, because that is an issue that, especially in, well, I shouldn't say especially, but it's common in the Black community to sort of hide your illness, and we have to encourage our parents and other family members to tell the story because it can impact others. What I want to ask you about is what about the families that have really strong history? I currently have a family of a mom and two sisters, young 30s and 29, who have breast cancer, but their genetic panel is negative. Mm-hmm. All right? What can you tell us about that? And then secondly, what can we do from a research perspective to expand that, or that patient, to learn more about it?
Great question. Thank you. And I apologize with the lack. I mean, I could talk about genetic testing for hours, so it's hard to get all these points in there. But genetic testing obviously does not capture every risk that's in a family. And we do have quite a few families, like Dr. Vidal just mentioned, where many individuals have breast cancer and we just can't find the cause. A lot of times that could be there's a gene there and we just can't identify it, or there's limitations to technology, or multifactorial, just a combination of factors. So in the genetics clinic, even when I have a negative result, we still do spend a fair amount of time talking to patients about their residual risks, their remaining risks, and many patients are still in a risk range because of their family history to obtain some of this enhanced surveillance that I mentioned, getting a breast MRI, getting a mammogram potentially earlier. So we usually recommend mammograms start 10 years before the youngest diagnosis in the family or by age 40. MRIs, same thing. MRIs can start in the hereditary setting in the early to mid-20s, but again, just depends on family history. And those screening methods would be covered, or should be covered, by most insurance companies as long as the patient meets a certain risk threshold. And we have methods of calculating that out for our patients. So I think there's still many options for individuals who have a family history of cancer, and it's important for them to realize that. And I'm not a doctor, obviously, so I would recognize these higher risk families and refer those patients to the appropriate specialist. And I'm lucky because we have a breast center right in West Cancer Center. We have a high risk nurse who follows all of our patients. And in terms of research, there are a couple different studies that are looking at the genetics behind breast cancer in families like Dr. Vidal described, that do rely on participation from a lot of different family members, but I can help identify those for our patients and help hook them up with various registries if they've got genetic results that are a little bit inconclusive. So there are definitely ways that we can start studying these patients a little bit more. Yes.
Nice talk.
Thank you.
The cost of whole genome sequencing is decreasing month by month, and so you showed that one slide of the red flags really indicating screening, but are you anticipating a time when patients will routinely have whole genome sequencing and it will no longer be just a sub-selection of patients that have specific risk factors?
Yeah, great question. I don't think that time is very far off. And when it comes to whole genome sequencing, that's not anything we're doing in the clinical setting right now when it comes to hereditary cancer. So we're looking at a subset of hereditary genes for our patients, not the whole genome. But it probably is going to start heading that way in the next, who knows, 10, 15 years. I think whole genome sequencing has gone from about $10,000 now to maybe $5,000. Most insurance companies won't cover it for cancer purposes, at least. So, yeah, I mean, I think it's going to be part of our future, and I think that's where, again, all of us are going to have discussions with our patients about, that type of information, and if patients really want to learn it, and what it's going to mean for them and their families. So it opens up a lot of other questions and ethical dilemmas.
Thank you. Just for the interest of time, I'm going to move on the agenda. Next up, I'm going to introduce Dr. Jason Porter. Oh, yeah, sorry.